morning. I use this bell mic so I can taste the floor a little bit. My name's Bob Parker. I'm a geriatrician. I'm a clinical geriatrician. I work over at the medical school. Our clinical site is primarily at Christus Santa Rosa Northwest. We're developing a community-based clinical program that emphasizes continuity of care. We actually follow our patients through the nursing home, the hospital, the outpatient clinic, and rehab. So we're trying to eliminate some of those errors and handoff. I've had about 40 years of experience in geriatrics, and still don't know much about it. But I'm going to share with you today what I have learned. One of the things that we're going to talk about today on the physiology of aging, I'm going to try and answer the question about why do we get older and how do we get older. I really like this picture. I'm also on call, and I got about 3 hours of sleep last night, so excuse me. If you can have somebody call them back. So I'm going to try and define what aging is. We'll discuss some of the various theories about aging, what some of the physiologic changes are as we age. I like to tell my residents and internal medicine and family practice friends that geriatrics is just as different from internal medicine as pediatrics is. As we age, we have different diseases, we react differently to drugs, and we have a different physiology. Then we're going to talk about the functional reserve capacity, which I think is an important concept in aging, and then we'll look at some specific organ systems. How old would you be if you didn't know how old you are? Satchel Paige. He was a famous baseball player back in the 20s and 30s. And he was completely uneducated, but he made a very wise statement. Really, only as old as you're feeling. Because you can still do everything you could when you're 30, essentially 30 years old. We all know people who are young in their 70s and 80s, highly functional. We all know people that are impaired in their 30s and 40s and very disabled, and they are in fact frail, elderly. So, what is the difference between life expectancy and life span? Well, human lifespan really hasn't changed at all in the past several hundred years. But life expectancy has. Life expectancy at birth in 1900 was only 49 years. On average, that's how long we live. Lifespan, of course, is how long is the longest living among us live. The longest was Jeanette Calment. She was 122 years old. And 164 days. She was a French woman. She rode her bicycle every day until she was about 100. She would smoke a cigarette once a day. I don't think she was a real heavy smoker, but she's still the longest lived human being. She died in 1997. So if we look at the life expectancy since 1900, the top line is females, bottom line is males, and you can see that life expectancy has been gradually increasing, almost a linear pattern, and we're expected to live up to age 84 for females and 79.7 years for men. Now, this slide demonstrates the difference that socioeconomic factors play in life expectancy. It's a little complicated, and basically what this shows, this is looking at death rate per 100,000. Here we have capital income, per capita income, and here is income inequity-based quartile. So you can see that the death rate is the highest for those that are in the lower economic strata. Those that have the lowest death rate have the largest income. Intuitively, that's obvious. Here's the statistical proof of it. The more money you have, the more access you have to health care, the better your diet, less obesity, better education, on and on. Now, national differences in life expectancy are somewhat disappointing for our country. This is the United States. This was done in 2002 to 2013. And only Mexico actually had a shorter life expectancy than the United States. The other European and industrialized countries fared much better. I'll let you decide what the cause of that is. Yeah. What's the difference in life span between species? Remember, span is how long the species can live, the longest lived organism in that species. Mice in laboratories can live up to 4 years, dogs 29 years, cats 36, horses 62, chimpanzees 75, elephants are up to 78, humans, of course, first one 122 years. The Galapagos turtle is thought to be 190 years old. Bowhead whales can live up to 211 years. You see a pattern here. The larger animals, a little tricky. Larger animals tend to live longer. Okay. Now, another concept is this concept of intrinsic versus extrinsic aging. So we define extrinsic aging as environmental or habitat pressures that are outside of the organism. So that might be pollution or war or failing or any number of things. Intrinsic are aging conditions that are intracellular, genetic, or organic based. Think about that as we go along, the differences between intrinsic and extrinsic factors and forcing aging. Why do we get older? What is it? Aging is defined as a progressive loss of function accompanied by decrease in fertility and increase in mortality. Pretty obvious. It's a loss of homeostasis. Homeostasis means the ability to maintain our internal milieu, our internal environment in a normal range. For instance, to be able to concentrate our urine, which is our water and salt, to be able to maintain our blood pressure. Any variable that you can think of, as we age, it's more difficult to maintain those variables within the same range. We have much more variability in blood pressure, pulse, respiration, kidney function, whatever. That's the loss of homeostasis. I think that's really the hallmark of aging. Some of the characteristics, we see increased mortality, of course, with aging, decreased ability to maintain homeostasis, as I said. We have temperature regulation is a good one for loss of homeostasis, because everybody knows that their 90-year-old relative likes to keep their room at 80 to 85 degrees. They have trouble maintaining their body temperature. My father actually liked to keep his at 85. And until he put on more and more clothes, he wouldn't do it. And it's quite uncomfortable to be in their room with them for the younger people. Fluid balance, too, is difficult because, for the same reason, they have trouble with getting dehydrated easily. They're unaware of it. They are very fond of dehydration. There's decrease in the physiologic reserve capacity. We're going to come back and talk about that a little bit more later, about this functional reserve capacity. There's an increased vulnerability to many diseases, such as malignancies, cardiovascular disease, from hardening of the arteries, atherosclerosis, and infection. These are some of the more common causes of death. So, we don't really know why we get older. We've got a lot of theories. We do know that we don't have a choice. It seems to continue no matter what. Some of the more common theories now is the evolutionary theory, the free radical, the cellular aging, genetics, and accumulation of waste products, or trash. And we'll talk about each of those briefly for a second. First of all, we'll look at the evolutionary aging. There really isn't any pressure from a survival mode, if you think of in the Darwinian sense, to live beyond the age of reproduction and rearing the offspring. So once those tasks are completed, there is no evolutionary advantage. There's no selective pressure against genes that might be deleterious later in life, particularly if they happen to be ones that have some advantage in reproduction or childbirth. So this theory would predict that specific genes are selected to promote aging are very unlikely to exist. Aging is not programmed, but it results from accumulation of somatic damage. This is according to this theory. Longevity is regulated by genes controlling levels of activity such as DNA repair and antioxidant. Free radical theory, which is still very popular, talks about oxidative stress. This is an accumulation of large molecules that are highly reactive. They actually interfere with some of the biochemistry intracellularly. The gene insertions can increase catalase and superoxide dismutase. These are enzymes that help manage the free radicals. So in Drosophila, which are fruit flies, by inserting these genes into the fruit fly DNA, their lifespan can be increased. So that's some support of the oxidative stress theory. But unfortunately, our studies with antioxidants in humans show that it doesn't really delay senescence or aging. Caloric restriction and aging. A lot of the studies on caloric restriction were done here in San Antonio at the Barbershop Institute on Aging. We found that caloric restriction to about 60% of the free diet leads to 30 to 40% increased average and maximum lifespan in rats, mice and rodents. It also retards age-related changes. It's most effective immediately after weaning. It's very, still significant when compared to greater caloric intake and exercise. And we don't know if it applies to primates. I had a neighbor who was a neurosurgeon who had retired. He went on a caloric restriction. He got down to what I thought was anorexic levels. And he thought he was going to live for quite some time. Kind of lost track of him after he moved, but I don't think there are very many humans that are willing to restrict their caloric intake to 60% of what they usually eat. But it does work somehow in mice and rodents. Also, we'll talk a little bit later about some of the other work, but there is a drug that mimics the effect of caloric restriction, rapamycin, you may have heard about. Cellular aging. Dr. Hayflick back in the 50s, and incidentally, Dr. Hayfoot is still doing research out of California. He postulated that there's a maximum number of divisions that a cell can make before it dies. And he did this in fibroblasts, and there are about 50 to 70 divisions. And this is because of a number of reasons. One, there's a change in signaling, chemical signaling and transduction. The telomeres, the little caps on the end of your DNA, get shorter each time the cell divides. Progeria, which is that disease that occurs in children where they age very rapidly and die of old age in their teens, have very short telomeres. The genetic theory of aging is, states that there are certain SNPs, or single nucleotide polymorphisms, we call them SNPs for short, are associated with longevity in humans. Like in the fruit fly, specific genes, in C. elegans, which is a laboratory worm that's studied commonly, certain genes can dramatically increase or decrease life expectancy. Lifespan, I should say. Very straight. Most of these genes are related to stressors, such as heat, ultraviolet light, free radicals, things that damage tissue. So this theory says that lifespan is programmed before birth. I might mention in this theory that there are certain populations that have a history of long lifespans. There's a little village in Italy that you may have heard of, and I think there's another in South America somewhere that I read about, I can't remember where the men tend to live longer than the women, and often live into their 90s or even into their 100s. Waste product therapy is associated with increasing pigment, or the stains on the slides. It's called lipofuscin. It's a pigment which is basically cellular debris that accumulates as the cell ages. And it's a result of autophagocytosis and other processes. And it may be a form of the end product of free radical-induced peroxidation, this chemical reaction from free radicals. So normal aging versus disease. What's normal? What's abnormal? The Danish twin study is a study that's been going on for almost 100 years, where they looked at identical twins, and there have been a number of studies done on this database. And one of these studies showed that genetics accounted for only 25% of the variation in longevity. The environment accounts for about 50%. That would be your annual income, whether there's pollution, if you live in a war zone, or if there's a famine or some plague. So the other 25% is probably just luck. When you get hit by a car or by a vehicle or hit by lightning. The other thing that we found in this study is that different organs in the same person age at different rates. Which is kind of interesting. If you think about it, it seems like they all ought to age at about the same rate. And so in a sense, normal aging resembles chronic disease. Now, rapamycin, I'll talk about a little. It's a drug that's actually on the market. It's called sirolimus, and it's used in cardiovascular stents, and it's studied a lot out of the bar shop also. And it inhibits one of the mTOR sites, and it mimics the auric restriction. So it actually can cause a reduction in the process. It decreases the vulnerability in rat models to Alzheimer's, for instance, to malignancy. Sounds like a cure-all. Every time I hear this talk, I want to know, well, where can I get in and start taking it? Has not been approved for use in humans. We don't have any studies in primates. If you look at the rapamycin pathways, it stimulates cell growth and proliferation. It increases this process, autophagy, which actually is the cleaning up of debris we talked about earlier. And it decreases the inflammatory process, which in turn, of course, decreases the aging process. It's a major nutrient sensing pathway. So it controls energy production. It's a very important pathway in itself. It helps regulate appetite, body weight, and like I said, it kind of mimics the caloric restriction model. Okay. Let's talk about the physiology of aging in specific organs. We were talking earlier about homeostasis being a problem as we got older. We've lost the ability to maintain homeostasis. This word is not a real word. It's just sort of made out. Homeostasis is the opposite of homeostasis. It's a concept where with normal aging we have a decrease in our ability to withstand external stresses and challenges, and our homeostatic mechanisms aren't able to keep up with it. So in this example, if we look at our functional reserve, it just sort of declines as we get older, the ability to maintain homeostasis. The physiologic reserve capacity is sort of represented by the space between these two values. And what that means is that all of our organs have excessive capacity to maintain our homeostasis. We have a lot more kidneys than we need. That's why young people can donate a kidney without going into kidney failure themselves. Or donate other organs, part of the liver. Each year, for instance, in the lung, we lose about 5 milliliters of vital capacity of the lung. And as we age, that reserve gradually diminishes so that there's very little of it left. These are the reserves that are already in use. So what happens is we approach this line right here when we're in our 70s and 80s and 90s. There isn't that much reserve left. So if, for instance, you get pneumonia in one lobe of your lung, there isn't that much left in the other part of the lung to compensate, and these people might wind up in respiratory failure or on a ventilator. Also, somebody that might have some problem with dehydration may go into kidney failure simply because they don't have any functional reserve in that kidney. So this is why when elder people, this is the physiology that's different that I was talking about. As older people get older, get ill, they often will have problems maintaining homeostasis when they get sick, and it can precipitate respiratory failure. And then we get the domino effect where another organ will start to fail, perhaps the kidney, and it turns into sort of a downward spiral that some of my residents refer to as circling the drain. And it's almost impossible to stop that, because once that starts, so that physiologic reserve is important. This is another word that's used to describe that, functional residual capacity. All organs have this. Like the kidney, you can lose up to 7% of nephrons, the functional unit before the creatinine, the waste product, starts to rise in the blood. Symptoms occur when the organ capacity drops to the level that affects that patient's activities. And that's different for different people. As an example, we talked a little bit about water balance before. We always read about in the summer, elders, particularly those who don't have air conditioning, often will get dehydrated to the point where they're coma and they're admitted to the hospital. And you think, well, why in the world didn't they just drink some water? They lose that homeostasis. They're not aware that their volume depleted. Thermal regulation we talked about. Regulation of caloric intake. We don't have that satiety level that we used to have. So just keep eating. Heart rate variability. Too fast, too slow. Keeps the cardiologist busy. Renal concentrating. Kidney cannot concentrate urine as well as it did in the past. Bone mass. We can't maintain the bone density that we used to have. These are just a few examples. Skin. Now we're going to talk about specific organs. This was Cher when she was 67. I actually saw her in Las Vegas, maybe it was a year or two ago, and she was wearing pretty heavy stage makeup, and she wasn't on the stage for very long. But this picture was taken when she was 67. Now, she's had a lot of work, a lot of plastic surgery, but my point here is you really can't tell how old a person is by looking at their skin. Oh, this slide's out of order. Now, the ages on these two, now these are really extreme. This is what I mean that you can't tell by looking. This patient, or this person, it's an American Indian that's spent her entire life outside in the weather. That's sun damage. This is a monk who probably has never seen the sun. And have a wrinkle on him, it looked like. And he's 91 years old. Botox is not going to fix that. So, intrinsic aging of the skin is that which occurs physiologically within. What we were looking at before is extrinsic, solar damage. So we see gravitation, we get the jowls, we see the expression lines getting bigger with the loss of elasticity. The skin gets thinner, there's decreased vascularity and yellowing, and much slower wound healing in the skin. We all know this from dealing with our parents. The extrinsic that we talked about is mostly from sun exposure. Smoking and wind can do similar damage. Smokers have very characteristic changes in their skin and their face. And again, we see an exaggeration of the intrinsic changes, coarseness, pigmentation, modeling, telangiectasia, those little red blood vessels, the actinic keratoses are little things that turn into skin cancers as we get older. Of course, there's very deep wrinkles. Looking at the heart, the cardiovascular system, we see a decrease in the maximal heart rate as we age. So we're not able to get our pulse rate up as fast as we could before. Our cardiac reflexes are less. The maximal oxygen uptake, when measured in the laboratory, decreases. So there's a decline in functional reserve that's much slower than those that exercise. So I think Michelle mentioned that exercise is an important part of slowing the aging process. This is a really good example of that. Functional decline is a lot slower in cardiac performance if this person is exercising. And it's dose related. The more you exercise, the better it is. Now, arterial stiffness will commonly increase with aging, but it's not inevitable. A lot of older people have fairly normal arteries. It's talking to my radiologist the other day when we were looking at some films, and he was looking at the carotid arteries. And one of my patients who is about my age has got some calcification. About 50% of the artery inside of the cranium was calcified. And he said, "Oh, that's normal for aging." I said, no, wait a minute, I don't have that. But apparently this is just an inevitable part of some calcification of the arteries. Now, I haven't taken a picture of mine, but I probably have some. Now, this is another example of functional reserve capacity. Here we're looking at VO2 max with age. VO2 max is something that we measure as a level of fitness in athletes, how much oxygen really used maximally with exercise, which is proportional to the level of fitness. And you will see in athletes, the red line here is above the moderate activity, and this green line represents the sedentary folks. So the deterioration in exercise capacity with age occurs at about the same rate, but we start out with a much more capacity as we're more fit. Now, if we look at this line right here, the horizontal line, theoretically, let's say this is where symptoms might occur, where the person's cardiac output wouldn't be enough to get them through their usual daily activities. So the person, theoretically, or in this example, that's sedentary might experiencing shortness of breath and fatigue much earlier when they cross this line at age 50, whereas the trained athlete may not experience this until well into the 70s or 80s. So that kind of gives you an idea of the importance of exercise and the importance of reserve capacity. In the lungs, about 20 to 40 cc's decline in the forced vital capacity per year in adults. And the forced vital capacity is how much air can you blow out. And that's proportional to your lung volume or other parameters that we can look at that demonstrate the same thing. In smokers, the loss is about 70 to 80 milliliters per year. We're losing lung capacity 4 times the rate of non-smokers. But they don't have any symptoms for the most part. Why is that? They still have some functional reserve capacity. So in this example that I call Mr. Emphysema, typical patient would be a 70-year-old man who's been sedentary. And this actually happened. This guy came in because he couldn't play golf any longer after a case of pneumonia. He had a little more damage to his lung. He had severe shortness of breath with his moderate exertion. And he was surprised because it appeared to him that it came on rather suddenly. And he was confused when we told him that he had severe emphysema. So why did his symptoms occur sooner? Why is he just now feeling like it just happened? Well, that's the functional reserve capacity concept that I was talking about. He reached that line and just crossed it. And if he were a trained athlete, he would have noted this much sooner because he was asking a lot more of his pulmonary system. Everybody understand that? The muscles. A lot of change in our muscular system. 30% decline in muscle mass from age 30 to 70. And it's associated with a decline in strength and a decline in the number of muscle fibers. Now, when we do exercise as we get older, the muscle fibers we've got left still enlarge and increase in strength. So all is not lost. We do have the capacity to increase our strength even in older age, which is why we're so ambitious about physical therapy as patients require. Even in the very old, this is partially reversible. It's amazing what a good therapist can do. When we're young, I think it's about 60% of our body mass is muscle, the rest is fat, bone. In the elderly, as we age, that ratio changes. We're more 60% fat. Even though our weight may stay the same. So that's the reversal of the fat-muscle ratio. Muscle fibers are reduced by 25%. There's an increase in the slow versus the fast twitch fibers. There are two kinds of muscle fibers. The ones that we react quickly with are the fast twitch. Trained athletes have, and professional athletes have incredible fast twitch. We lose that as we get older. There's a prolonged contraction time. Lower threshold for firing. We get cramps. The aging muscle doesn't respond to anabolic steroids. So when we start our weightlifting program, we want to start taking testosterone to bulk up. It's not going to work. We talked a little bit about the kidney before. There's a decrease in the functional unit, the nephron, as we age. There's a decrease in the filtration rate with aging. We measure kidney function, and this is real important for people that are dosing drugs for patients. Because we use, particularly those that are excreted by the kidney, we use the Cockcroft-Gault equation to adjust the medication dosing based upon their creatinine clearance. Now, the glomerular filtration rate decreases with aging, and we measure creatinine as sort of an indirect measure. Creatinine's produced at a fairly steady rate, and we can measure the level of that in the blood. When the kidney quits working, it starts going up. Now, the creatinine comes from muscle. So since muscle mass decreases as we get older, the level of creatinine is going to stay the same or actually decrease. So it's not a real good measure just looking at the serum creatinine for kidney function. So this equation, Cockcroft-Gault equation, will actually estimate what the true kidney function is based upon age and sex and weight. There are other methods of doing it too, but many of the laboratories are actually calculating it. So you can have a patient that has normal kidney function on your chemistry profile that looks normal, creatinine's normal, but when you run the equation, they actually have stage 3 or even stage 4 chronic kidney disease. There's a decreased ability to concentrate in the urine, as we talked about, more vulnerability to dehydration, decreased ability to limit excretion of sodium. So the serum sodium tends to get lower as we get older. Often the normal's around 135, 140, a little above that. We frequently will see it around 130 in older people. And there's a decrease in plasma volume also, which may contribute to the problem with the blood pressure dropping when they stand up, with standing hypertension. Water balance problems, very common. Bone mass, from age 40 to age 80, we lose 25 to 30% of the bone in women, and men it's 10 to 15%. I had my bone density done the other day. We probably are underestimating the incidence of osteoporosis in men because we haven't been screening. I was actually osteopenic. I don't have osteoporosis yet, but my bone density was below normal for age-matched controls. And the bone loss in women is strongly correlated with the estrogen decline at menopause. Peak bone mass occurs about age 35, gradually declines as women get older. A lot of it has to do with what was your bone mass to start out bone mass enough to maintain safe bone density throughout the life span. This is a vertebral body, the cross-section of the vertebral body. And on the left is a normal one. And you can see the density of the matrix here is a lot more calcium. This is kind of a phantom osteoporotic vertebral body. These are real vulnerable to compression fractures where the vertebra just actually impacts upon itself. And this results in kyphosis. We get older, we develop these fractures, we gradually get more and more stooped over, pushed over, and we lose vertical height. Brain function, that's kind of important because that's where we live. What happens to our brain when we get older? There is a decline in performance in a number of cognitive tests that may be considered normal. These are not tests that require experience or judgment. There's some decline in memory, minimal normal decline, and in some studies, cognitive performance can be improved by vigorous exercise. There's actually been quite a number of studies now that show that exercise helps delay the onset or decrease the vulnerability to cognitive impairment as we get older for whatever reason. We don't know. And if we look at the aging brain, this is a normal cerebral cortex on the right. On the left, you can see the aged brain both in the lateral view and the superior view. And you can see that the sulci are much wider, the gyri are less thick, and with less brain mass. We actually lose brain mass as we get older. Is that normal? Yeah, that is normal. We see it on our CT scan. Does that mean you have dementia? No. This brain on the left could have had dementia or could have been in a normal cognitive function. This study looked at the heritability of cognitive functioning in Jamie's twins, age 70 and older. Lots of fascinating studies have been done in this database. And what they found was the overall level of cognitive functioning was highly heritable. But the rate of change, the decline, was not. So the rate at which it declines is the same from one person to the next, but the ability to maintain a higher level of cognitive functioning is, to a great deal, inherited. That kind of goes along with what we're learning about the genetics of Alzheimer's dementia.
Dr. Park, just real quick.
Yeah.
My father-in-law turned 100 in April, and he does the Sunday New York crossword puzzles.
And he's pretty good at it.
And and I'm like, I'm trying to figure out.
Congratulations, that's what we got. He's your father-in-law or your
No,
father?
he's my father-in-law, unfortunately.
Well, you're going to have to put up with your husband. That's wonderful, and it's such a delight to see that. I had a patient that came in the office the other day who's, I think he was 101, and he looked like he was about 80. You know, who would have thought that telling somebody they don't look a day over 80 would be a compliment? But this guy is living independently, drives his car, pays all his bills, reads the paper every day, does all of his gardening, takes 2 medicines, and hadn't seen him in a year. And I told him, get out of here and come back and see me next year.
So what do you attribute that to? I mean, he used to smoke, but he quit in his 50s. And, you know, it's like, I want to be him. I know.
How do we do that?
Yeah.
The way we do that is to work on that portion that we can control. We can't control our environment too much. Now, we live in the United States, so theoretically we have access to good health care. We can control our income a little bit. But what about that other 25% that's heritable? We can't control that. But you can theoretically at least control our weight, our exercise, and our personal habits, alcohol, tobacco, whatever. We all know what the healthy lifestyle is, but in San Antonio, very few of us actually live it. I work out 3 times a week. I do weight training. My cholesterol is perfect. My LDL is 85, and my HDL is 54. All of my parameters are still within normal limits. So I think, lifestyle is the only thing we can really control. Let's sue your parents for genetic malpractice. So we're going to have to control what we can control. And that's, unfortunately, our society really doesn't encourage that. So in the special senses, we see our hearing declining, and that's normal to a great extent. 39% of us over 75 are hearing impaired. We get hardening of the lens and cataract. That's actually a normal part of aging. Diminished night vision, and a decrease in the number and function of the taste buds, which is why Grandma likes to put some more salt in our food, and why we use more sweets, sugar, or sweetener as we get older. The immune system, why are we more vulnerable to infection as we get older? There's a decrease in T cell function, that's a normal part of aging, a decrease in the proliferation response to an infection to an external stimulus. And interleukin-2, at least in vitro, has a decreased response, a decreased antibody response, and re-immunizing all of our adults now for pertussis. I'm sure you've all seen that sign around where they have the cute little baby on the billboard that says no more kisses. So grandma gets her pertussis vaccine. We see whooping cough in adults fairly routinely. The immunization wears off. So we're re-immunizing people for this reason because the antibody response is increased. Increased vulnerability to autoimmune diseases from autoantibodies, and increased susceptibility to infection as a result of all that. So just summarizing this, if you're not depressed enough, aging is associated with increased vulnerability to disease. We have a decreased ability to maintain our internal environment, decreased homeostasis. Functional residual organ capacity gradually decreases. Can't do anything about that. But aging is not a disease, it's normal. We can affect it to a certain extent. And disability, not being able to do our activities of daily living with aging is not inevitable. We can prevent frailty. That's one of the things we do in the clinic. Exercise, diet, immunizations, just the routine preventive things. And a lot of them we can't write a prescription for because I can't make our patients do that. It's up to us as individuals. So Mark Twain said, aging is mind over matter. You know why? It doesn't matter. So, then we open it up to questions. Anybody else have a 100-year-old relative? I think they're just
My grandmother's 98.
Yeah,
She'll be 99 in October.
Pretty impressive, isn't it?
Yeah.
Functional status?
Huh? She's pretty ill. She's in a nursing home. Yeah. She's got.
What's really sad is when we do get dementia, we often will last 10 to 15 years beyond that.
Yeah.
And we're completely disabled and dependent on others.
How does stress play a role
Meaning personal stress, like when you got a bad boss or something like that?
or going to school and doing everything, yeah.
That kind of, we don't really, that kind of a study is impossible to do because you can't control all the variables. But the external stresses that we were talking about earlier, the extrinsic aging things, we can control, the smoking, drinking, and so forth. And a lot of the things that we do when we're under stress are not healthy things. You got to be exercising to reduce stress.
I'm a stress eater, yeah.
So it's our personal response, I think, to stress that really determines what it does. But there's no question that stress increases our vulnerability to disease, whether it affects lifespan or not. Somebody over here had a question. Yeah.
I did. It's kind of maybe a silly question, but I was wondering, do geriatricians see geriatricians, or do they see PCPs?
First of all, there aren't very many geriatricians. I think there's only about 30 or 40 of them in San Antonio. We train about 4 or 5 a year. There aren't too many people that want to be geriatricians because it takes additional training, and your patients have Medicare as a primary payer, which pays about 70% of what the commercial patients pay. So it's hard to justify from a financial point of view to take additional training when you have a lot of debt to make less money. So it's really, the people we recruit, this is really a passion to take care of elderly people. It's one of the most rewarding careers. Geriatricians actually have the highest job satisfaction rate of any physician, which kind of surprised me when I saw that, because we actually help people through the last stages of life too. But even that can be rewarding. So to answer your question, I'm not geriatric yet. I'm 69 years old, but I'm not geriatric. Why aren't I geriatric?
You don't feel it.
Right, I'm 35.
But you know, as I guess my thoughts are, I hadn't really considered if when you're over a certain age, regardless of how you feel, a lot of the PCPs don't understand the aging process.
Right.
You're
And
right.
so that's why that was what prompted my question, because different things, as you were talking about the renal, okay, they may not, my doctor has never said, well, okay, your urine looks good, but let me throw in this equation to see if it's actually functioning well. You know, and so there are some things that, you know, you would consider that most of the doctors out there would.
You're right. You're absolutely right. That is a little scary. Of course, I have a buffer because I know that stuff. I go to a physician. Most people don't. And most doctors don't. That's why I emphasize that geriatrics is as different from internal medicine as pediatrics. And of course, most doctors will say, well, I know geriatrics, I do geriatrics because I see old people. Well, heck, I see heart patients, I treat heart failure, but I'm not a cardiologist. So the logic doesn't work. And you have to look at the culture. This is a new specialty. The first boards were presented in 1988 as a specialty. So it's just now being recognized as a separate body of knowledge. Even though we have this enormous aging tidal wave of old people, the tsunami of geriatric patients, we're not prepared for it. So it's our job to train the healthcare providers that are working with these older patients. We're not going to have enough geriatricians. NIH is not funding, government isn't funding geriatric residency program or fellowship programs as well as before. It's not even a required part of the curriculum of medical students. This is typical of all society, you know. And when I was in college, I majored in chemistry, and we were required to take German to get a degree in chemistry. Why German? Well, back in the 30s, all the chemical literature was in German. That's why it was required. Well, that was ridiculous when I was in college, but it was still a requirement. So it just takes that long for our society to change. And I get real impatient with that, just like you do and all of our patients do. How do we change that culture? things are changing so rapidly. We never lived this long before. This is a new problem for our society.
But you know, apart from aging, I mean, I've been working in the CLC, and my background was family practice, well, ICU and then family practice, and aside just from the aging process and taking care of this elderly person, there's so many other issues that go with that. When I was a hospital nurse, I would just, the doctor wrote the prescription, I gave it to the patient, say, here, that. Now I have to think, okay, how are they getting home? Look at their functional capacity is like, okay, so do they need a walker? Do they need a wheelchair? Looking at the community, you know, who's out there to support them, their family support. Do they even have the money to buy the prescriptions? And so there's so many other issues that you have to look at with the elderly, apart from just them being elderly.
That's one of the reasons that we want to have a case manager in our clinics and in the hospital, and we don't. We don't have enough of them anyway, and I wager you don't either, because that's really takes away from your other duties too, doesn't it? And yet you have a responsibility to do that, because otherwise your work is, may as well not have done it if they don't have enough money to get their medication. Of course, this happens in the younger population too. They can't afford their medication. So I always ask them, you know, do you have any trouble affording your medication? It's amazing how many people start cutting their dose of insulin down, even young people, towards the end of the month before they get their next check. So you're right, we need better infrastructure to support this. But again, this is societal. In the meantime, we're going to be overextended. I'm glad you're doing that.
Well, you know, this is good in the VA because at least we have this, but I always think about the outside, you know, an elderly person who's on Medicaid and...
It's a problem in the community medical arena. With the VA system, from what I read in the paper, we have trouble getting to see you guys. Not true in all